I can't do
here for our first topic of the day, which is fluid resuscitation with Rachel Delargy.
Hi, everybody. I'm Rachel.
You have two online, so you have a total of 5. Oh, I'm sorry.
Just the camera?
Yes.
Okay.
You need the light?
That'd be good. That's fine.
Okay.
Okay.
All right.
Hey, I'm Rachel. I'm an ER nurse here at Fulton County. So we're going to talk about fluid resuscitation and IV pumps today. I know you guys start a lot of IVs for us in the field, and we really appreciate that. If you draw lab, then that makes it faster for us to get the patients taken care of. It's just better for the patient.
So we're doing it, drawing labs right now on stroke, STEMI. What else? Okay.
I know there's a few people that draw lab whenever they can.
Yeah.
I mean, sometimes you just can't, but
yeah, stroke, traumas. Yeah, I don't do it on traumas and everything, but I don't traumas. But yeah. Would that be better?
Yes, because it just makes care faster for them.
Okay. Like moderate, major trauma. We're talking about minor trauma. What are we talking about?
Really, anytime you start an IV, honestly.
Really?
Yeah.
Okay.
Because if we're gonna have, if you can do that, I know sometimes you can't, but we're pretty much gonna do like a CBC and a CMP. We're gonna check electrolytes and their white blood cell count.
Okay.
And red blood cell platelets. Those are all in CBC.
All right.
And we're going to do a complete metabolic panel almost on everybody. So it's also nice for the patient because it saves them a stick from lab. Yeah. It just makes their care faster.
Okay.
But I know sometimes you can't do it. But if you can, that would be nice for them.
Well, these longer transports, especially like if we're at Mammoth and we're coming here.
Right.
You can do it. Which the backside of that being far out, like the hemolyzation of it, what is the time frame on hemolyzation? That's a lot.
Yeah, it is, and it's quite a while actually, because like home health draws blood in the field and then brings it in. So it kind of depends on what lab you're running. So it's still good to draw it, even if you're in Mammoth or Horseshoe or wherever, if you can. It's still good to draw it because we can probably run at least some labs off of it.
Okay.
The only thing, like we're talking about fluid resuscitation, if you think somebody's septic, they have a fever, along with, if you think they have, fever's the number one thing.
Yeah.
If they're really sick and they have fever, they sound like they might have pneumonia or urosepsis a lot of times with older people. Sepsis protocol is 2 liters of IV fluid. And do you guys do antibiotics on the truck at Baxter? Any at all? You don't? Okay.
Well, just for open
fractures. Do we do that here? Okay. And so, okay.
And technically, it's a gray area. Tim says if you think we're going to go into surgery, that it's okay to go ahead and give it. But
good.
It's mandatory our protocol for open.
Good. Because if they come to the ER with an open fracture, we have to give antibiotics for, even if they go home. Even if it's, I just had last week a guy with a crushed finger that was an open fracture. We have to give NSF before they go home.
Really?
Yeah. So that would be good. If it's an open fracture trauma of any kind, they need NSF. Okay. So the sepsis protocol is 2 liters of IV fluid, but you got to be careful. You get into real gray areas. If somebody's got CHF in the ER, we usually start with 500 cc boluses. So, and see how they tolerate it. Okay.
Thank you.
So yeah, that's what we do in the ER. We just start with a smaller bolus, but almost always they still get at least those 2 liters. So even if you can get 1 liter in by the time they get here, the faster you can get started, the faster. And there you go again, with the patients. The lab, we've already got the lab, then the nurse is running to get the antibiotic first. So. As far as fluid resuscitation, you guys already know that. You're doing that anyway.
Well,
is that what you're wanting more?
The way that they're teaching, we'll do it whatever way the ER wants us. Well, I say that, but protocol standing. They're teaching now, like it's the less fluid you give, the better off you are. And I don't know if that's
And a lot of
because of the
reasons.
lab.
I know with trauma patients, they're wanting less fluid and
Mhm.
more blood, more
Mhm.
whole blood.
It's more of a permissive thing. If they're functioning and they're conscious and alert,
Mhm.
and they're able to answer questions,
Mhm.
you don't give a lot of fluids.
Mhm.
But and if your sepsis policy, can we get a copy of that and I'll take it to Tim?
Mhm. Yeah, I should be able to print that off of Baxter's.
Okay.
I'm not sure we ever had an actual like protocol.
Okay.
We just kind of followed what they needed. So
We can talk to Bozeman about it.
yeah, that'd be good if you suspect sepsis.
Mhm. Awesome.
Okay.
Awesome.
Okay. So anything else about fluids? Anybody?
LR versus saline.
As far as I know, we don't hardly ever do LR. None of our doctors like LR anymore. They just want saline.
Even with trauma patients?
As far as I know, yes.
Just saline.
Mhm.
Okay.
Yep. Okay. Want to do IV pumps?
Sure.
Okay. I'm going to start one and then I'm going to let you come up and program it, okay?
Oh, okay. Even better. You can scoot it up closer to the camera so they can see. I just want to wait. You want to what?
How's that? Can they see? Okay. That might be good, like right there. Maybe they can see right there. Okay. So I've got the line primed and ready to go. So this little blue piece here goes in the top of the IV pump and you push it down and it pops that open. It's already primed, so you have to just kind of run your finger down. It's going to tell you, it's going to make you push the line in 1, 2, 3, 4. So here's 1, 2, and then all the way down is 3, 4. And if you kind of pull on it a little bit, that helps.
Oh.
Pull down on the line and then shut your door and then you pull that back out. And it's going to walk you through everything. I don't know if you can see. I think they can.
Yeah, looks like
it says new patient. Yes. It's automatically going to populate to adult care. So you just say, okay. And then you can start typing in the name of the medicine you're going to give. Like if you were going to give Levaquin, you could start typing in Levaquin like the old, the old phones,
yeah.
you know. But most of the time, we're just going to give IV fluids, or else you're going to get the pump already programmed. So if you're looking for a drug and it's not in here, just type in IV, and you're just going to set your rate, so you can run anything off of IV fluids. Does that make sense?
Mm-hmm.
So you just type in IV, and it gives you two choices. The first one says IV KCl or just IV fluid, so you just go down to IV fluids.
What's KCl?
Potassium.
Okay. Oh, duh. Okay.
Okay.
I thought it was some big long name.
So once you say okay, it's going to bring you to this screen right here, and you're going to set the rate. We can do bolus. If you want a bolus, just set your rate at 999. That's the most it'll take, and that's going to give it over an hour. So 999. It's going to warn you, hey, it's above this limit. So is that okay? Yes. Volume to be infused is whatever you want, 1,000. Okay. And then all you have to do is hit run. It's going to ask you, which I have it blocked, but it's going to ask you, are all clamps open? Is tubing kinked? Are the drops flowing? That's when you need to look up and make sure.
Oh, it's flowing.
It's going. So you can hit stop. You can just kind of play with it. Just come in and play with it. And we've always got extra ones in the ER, and we'll go over it with you anytime. So, okay, so you stop that and say you want to go back. There's a clear program. You want to clear the program? Yes. Okay, so most of the time you're going to get the patient with the IV pump already set up. Like say we sent a patient out last week on Levophed. So If you're already at your adult care, I'm going to say, okay, start to type in Levofed. These are all pre-programmed in here. I helped set those up a long time ago. So if there's one that's not in here, then we can add it to it. So we can go down to Levofed. Okay. So our Levofed protocol, which we have on a written out sheet, and I always take that into the room with us so we can look at that and we can send that with you. So we're trying to increase their blood pressure with this it's norepinephrine. This is the starting dose.
When you say it's in there, you just brought up a good point. Is it by the trade name or is it by the generic name?
Somebody besides me completed the setup, so some are one way and some are another way. So, okay. But most are by the brand name. Okay. But it's going to automatically populate with the lowest dose, which is 5 mics per minute. And it's already got your rate set. So you're not trying to calculate a rate or anything. You're just looking at a piece of paper with a protocol.
So the rate will be set for you.
Yeah, the rate would be set. So with this last patient that we had, we increased it from 5 to 6 because her blood pressure was still like 80s over 40. So we increased the dose one step and off of our paper protocol. And so it went from 5 to 6. Mm-hmm. So then all you have to do, this is highlighted. So all you have to do is change it to 6 and see it automatically calculated your rate.
All right.
You still have to, and you might have to do that on the way, you know.
How do you increase the dosage?
Mm-hmm. Just like that. You're just going to hit run stop.
So do that again.
Okay. Let me go back.
Yeah.
Okay. Well, let me say,
because I was listening, but I wasn't watching.
Right. So let it go ahead and like run, and then we'll stop it.
You need a trash can for the food?
Yeah, probably. It doesn't drip very fast, but it does drip.
Well,
okay, so
it was running.
Yeah, I had it at 999. Okay, so okay, so we're just gonna you're coming into the ER. You're coming into the ER to pick up this critical patient, and they have a Levofed drip. So the doctor says, hey, if their blood pressure doesn't come up over 90 or over 50 in 30 minutes, then I want you to increase the dose. Mm-hmm. You can ask them, okay, well, what do you want me to increase it to? Or do you want me to call you or whatever? But you can also take that paper protocol that we have and you can just bump it up to the next level. So it's running, you're in the back of the truck, you're just going to hit stop because it's run stop. Program primary or secondary because you're going back. This is a primary line, it's not a secondary line. A secondary would be like if you had an antibiotic piggybacked into that. So it's going to be primary. It already, when you hit primary, it pulls up what you've already got in there. So it already shows Levofed at 6 mics per minute. Here's your arrow right here. Always down here is going to tell you what you need to know. So you have to highlight up to what you want to change. So go all the way up to your dose, change it to 7, and it changes your rate again. Okay. And then you have to okay back down through everything. It gives you an opportunity to change that if you want to, and then okay again.
But you shouldn't have to mess with that, the second one. The rate, right.
Right, you shouldn't have to change the rate. And then you just run and it goes back to, and if you watch it, it's going to keep flashing. See, it's going to tell you what dose it's running at and the mils.
Can you hit dose change right here? Will that change?
Yeah.
Oh, okay. So that's just a quick,
easy way.
Okay.
And you don't have to stop it when it does that.
So, say you do have a saline piggyback with it, or a D10, D5, whatever. How do you flip from one to the other? Because I know you said it was on the menu a while ago. Mm-hmm. Is it the same process? You just flip to.
Yeah, if you were gonna look at your secondary, I think you absolutely have to push the run stop to be able to look at the secondary.
Doesn't know.
Well, you've already got it programmed in.
You programmed the second bag in there.
When you put it secondary.
Oh.
And then it'll, so say my Levaquin's going at 100 mils an hour, and then I want my bolus at 999. I'm going to program my secondary at 100, and after 100 mils, then it's going to automatically kick over to the 999. And whatever's hanging higher is going to go in faster. So it doesn't matter what you have programmed. If you have your Levaquin hanging down here, you're going to run in your saline. So you got to pay attention to that.
Even if it's like a little 50 versus 1,000?
Whatever's higher is going in first, unless you have your roller clamp. Unless you have it clamped off. But if you have it open, that's easy to do. Okay. So, want to.
When it starts beeping. Oh, I will. What do I do?
Well, another thing that happens is air.
Yes.
So.
Every time. Every time.
Listen, if it starts beeping air, even when it's running, you can still pop that in and it opens up. I mean, what do you do if there's air? The only thing I know to do is run it through.
So you take it completely out?
Yeah.
Okay.
Take it out and run it through.
I've seen some do a syringe. You just pull it.
A lot of people get really butthurt about air in the line, but the doctor told me once that there was over 500 mils of air put into us. They put it into themselves, and nothing happened. I've seen people.
Yeah, and plus at the end of that,
I don't freak out.
It's an air bubble filter too.
There's the air will accumulate right here too.
And also at the very end, it's supposed to help with air bubbles. So do we need to pull, or do we just need to?
No, it's easier for you. It's easier for me to just, because if you're going to pull with a syringe, this is going to have to be out anyway. So you just, unless it's a whole entire line of air, then all you need to do is just open the clamps and let it run past the pump.
I get panicked when I'm thinking, okay, they need.
I know.
Like their blood pressure's already low, and I'm pulling out so many cc's of this medication, and they're not going to get it because I'm just throwing the trash.
Well, and this is faster to me anyway.
Yeah.
Just run it below the air below the pump. Yeah.
Yeah, that's people.
Well, another thing, when you prime your lines, if you turn the first little Y side upside down, then you'll see the little air right here, and then it's already below the pump, and that saves you a lot of time.
So tap the hub.
If you're priming it before you put it in a pump, turn it upside down and tap it. But you're probably going to get the pump already done, set up with the line and everything.
I don't know how many times I've called them 5 minutes out. So I'll wait like 2-3 minutes in the truck before we take off, and then it never fails. I'm 5 minutes down the road,
and it's air. Because we're moving the patient, and when you move the patient, we need to be more careful when we're moving them in here to keep this above the IV pump.
There it is. Inactivity line. Well, it's hard when you're trying to transfer a patient, and then you're taking it from one pole to the other.
Right.
And, I'm always nervous when I hit the wrong button to clear out the whole damn thing. Me too.
That's okay. We'll just reset it. If that happens, just call. If you can't do it, just call us and we'll just walk you through it on the phone.
I'll just run it through. Just titrate to blood pressure.
Yeah.
It's going up. Okay.
Hey,
pause it.
Okay, so
what else you got in those ones?
you want to have them come up and,
sure.
Or do you want to do all that at the end for the online people?
It don't matter.
We can do this and port access at the end if you want to.
Okay. I'll go first.
There's 2 pumps, so if anybody wants to start, you can. I'll just leave this one hooked up, then they can see you too.
Okay.
There.
I just need to turn it off and then just like restart it?
Yeah, restart it. Take this out so you can do all of that too, just so you know how to do it. And then turn it off.
Hand model this morning.
Anybody want to do this one?
Yeah.
Okay.
And see, and this is usually how I get it. Yeah, tied. You're like, how is it even possible?
You probably remember because these were Baxter's old pumps, so you may remember.
Don't let me down over there, Seth.
Baxter, since the takeover, since they've given us all this stuff over the years,
I know.
still have to work on
You should know how to put it in. Here's a trash can if anybody needs it. And it tells you what to do on the screen too.
So how many, like how many inches? If you guys out there in Zoom land have questions, please get them in. How many inches do we need between this?
You just need enough for your whatever, however how tall your pole is.
Not to be so tight. Yes.
Pretty tight.
Yeah, it goes.
Okay.
Okay, then you have to,
Pull this tight.
and you have to kind of push in on all those spots, and it'll tell you.
Okay.
Now close the door. Pull this out. Now you should be able to set it up. Okay, it's telling you again, so something's not in correctly.
Of course.
So push your. I would pull this out and try to start again. Okay, make sure that's pushed down. Now pull this out. There. Okay.
I'm pushing. Okay. Oh, okay.
And then you're going to find whatever drug you want. If you have to start, is there any kind of drug you would start a drip yourself? Dopamine? Okay.
Huh? Yeah.
Well, if you're starting a drip, then you need to have IV pumps, right?
Mammoth has one. I think
Okay.
Salem is supposed to have one, but I don't know. We haven't had one. Because people keep taking it off. Oh, really? Yeah, probably.
Yeah, they keep taking it off and putting it in the ER.
My fault. No, it's okay. No, I'm saying that's what it is because they don't realize. So we just need to get a designated pump that says Salem truck and keep it up in wherever.
Oh, so it's kilograms.
Oh, okay.
So whatever you think their weight is divided by 2.2.
100.
Yeah.
What?
Yeah, there's a lot because they're programmed for.
Okay, so that one didn't have the dose in it.
Do you have a protocol in the truck?
Do
Do you have a protocol for dopamine in the truck like that you're looking off of?
It's 2 to 10 micrograms per kilogram. So
Okay, so start at 2. When you type in 2, then it's gonna set the rate.
7.5.
Yeah,
Well,
and it's gonna
set up for ER anyway.
it's gonna set your volume to be infused because your protocol probably says to mix it in 250. So,
Alright.
but you can change that if you have to. But then that's gonna change your dose and everything too.
So how do I go down?
You just hit OK, and it'll work through. Okay, below lower limit.
What does that mean?
Okay, so I didn't set these up. You did.
Okay.
So some of them are going to give you a false message. So I'm just gonna have to know what I guess.
All right. You probably need to say that louder where they can hear.
Okay.
So Rachel said, pharmacy set up on this this dopamine drip. We set it at 2. Pharmacy had set it up previously. It said that it was a lower dose than what was recommended. Right. They recommended 5. We have the ability to override that.
Yes.
So it will give you a false message. Okay. On that. Okay.
I'm hoping that those change, and I'm hoping we can go back and reprogram the IV pumps.
We could also just talk to Dr. Bozeman though and see what his recommendation is for the lower dose. If it's gonna, because it's a 2 to 10. Yeah. He may just say you start at 5. Well, that's I wanted to say that start at 5 and you titrate up or down depending on what your pressure is. Right. So it may be something that we could. Oh, correct. Now it is. We had that discussion. Did you not receive the email? We'll talk about that later.
Thank you.
All right.
Okay, so then pump stopped, push run to start. If you want to start it.
You got it downstream
Quick,
inclusion.
freak out.
Get the bags.
So
Get the
my
bags.
ball. All right, check flow or drips.
Our drip's flowing, which
No.
when you have a rate of like 6, you know, that's gonna,
No.
you're probably not gonna see it. So
Okay.
I just say yes. And then if there's a problem, it's gonna beep and tell you that there's a problem.
Well, that sounds
So
terrible.
there, you got it.
I got it.
Yep.
Woohoo! Next
wanna
time
do
we
it
go to
again?
the ER, you're gonna be like,
Get over here and program this pump.
Yeah. okay, so I want to stop. All right, go settings.
No.
Oh no, I don't like that.
Don't give me a full letter.
Review. Okay, so review takes you back to the menu.
And you can play around with it too. You're not gonna, most of this, unless you hit hold or stop, it's gonna keep running while you're trying to figure out what to do down here.
Okay.
Oh.
So I want to change this to 5, and that's it.
That's it. And then say, okay.
Huh?
And it's gonna make sure that, you know, if you've changed it, that you really want that big of a change. And you can say yes.
There's 2 there.
Now there's gonna be some air come through there. Then you're just gonna push it down, pop the door open, run the air below the pump, and put it back in.
So how, she has one there too.
Mhm.
How much should we dispel when we dispel?
I would just run, you can see the air come like right here. You can see, and once it's right here, then that's fine. You can just
Once it's just passed.
Yep, once it's past the pump, then it'll run.
Okay.
It'll run and most of the air will accumulate at these ports.
So if the air does accumulate at ports, is that a problem?
No.
Okay. You just shake their arm until it comes out. You like that? I did.